5,
4,
3,
2, 1.
Hello. On behalf of the European Society of Cardiology, I welcome you to the Best of the ESC 2015. This year in London, we had 5 days of presentation of new science, of new clinical trials, new hotlines, new updates, and many other important information that was provided at the Congress.
2, 1.
But if you did not have a chance to be here, all this will be summarized on the Best of the ESC 2015, where we will have a set of experts that will address the main topics in cardiovascular medicine, so you can expand your knowledge and you can do better patient management so you can reduce the burden of cardiovascular disease. Enjoy the Best of the ESC.
Ladies and gentlemen,
Now the summary.
You'll be hearing from a Nobel Prize laureate sharing her discovery on telomere lengths and aging. Find out how spironolactone could be of great help for patients with resistant hypertension. See how FFRCT could reduce the unnecessary use of invasive angiography. Discover how the new ESC guidelines will impact clinical practice. Hear more about the unexpected results on treating sleep apnea in patients with heart failure. And find out the long-term impact of first-line catheter ablation for atrial fibrillation. And now,
welcome to the Best of ESC Congress 2015.
Welcome everyone. I'm Keith Fox and here we are at the Best of ESC 2015. Why are we doing this? We're looking behind the headlines to get the insight of some key international experts onto what's really important, what's significant for your patients, and what may change practice. And we're going to see that there are going to be new treatments and also some new applications of old treatments. I have the pleasure to be with Genevière A Derumeaux, the current chair of the program committee of the ESC.
Thank you, Keith. We have fantastic panelists today with us to cover the different topics. First, let's begin with Janina Stepinska, coming from Warsaw. She will cover the acute care. Then Bryan Williams, coming from London for hypertension. We have Victoria Delgado for valvular heart disease and cardiovascular imaging. She's coming from Leiden. We have John McMurray coming from Glasgow for heart failure, Sanjay Sharma from London for prevention, Cecilia Linde from Stockholm for arrhythmia and sudden death, and Marco Roffi for intervention and cardiac and coronary artery disease coming from Geneva.
Geneviève, the spotlight of the Congress was on the environment and the heart. So there have been some new insights here.
Yes. Let's see the movie.
Great.
You are watching the Best of the ESC.
Elizabeth Blackburn is a biological researcher who received the Nobel Prize in Physiology and Medicine for her co-discovery of telomerase, the enzyme that acts on the telomere length. In London, she participated in a special session on the role of cellular senescence in aging and cardiovascular disease.
It seems as if the premature senescence of cells, in part caused by shortness of telomeres, may be playing a role in cardiovascular disease in ways that perhaps could be prevented better than we're doing now. I think a big theme of this meeting, which is that a lot of cardiovascular disease is preventable. What we've learned about telomere maintenance is those very same things that are reducing risks of cardiovascular disease, lifestyle changes, are the very ones that improve telomere maintenance in healthy and non-pharmacological ways.
Environment and the Heart was the Congress spotlight of the ESC 2015. An experimental study reports on the direct effects of pollution on healthy and cardiac patients, and it gave a clear demonstration of this new risk factor.
Air pollution has these bad effects on cardiovascular disease through
combustion-derived nanoparticulates, and if you take them out, the health effects are no longer seen, and the problems with air pollution are lost.
So we have now new insights into the consequences of environment factors, and we have a new risk factor, premature aging, with a new biomarker, telomere length. So Sanjay, can you give us a little bit more explanation about what are the telomeres?
Yes, the telomere is a small segment of DNA that's found at the tip of the chromosomes, and its main job is to maintain DNA repair during cell division. Now, with progressive aging and cell divisions, these telomeres start to become smaller to the point that the cell can no longer divide and ceases to live. There is certainly an association between a short telomere, cardiovascular disease, degenerative disease, and even aging, but the good news is that exercise and other healthy lifestyle measures do preserve telomere lengths, and people that exercise modestly have a telomere length that's about 10% greater than sedentary individuals and looks the same size as someone who's 6 years younger. So that may explain why exercise gives us another 3 to 6 years of life.
So do you think that we are ready for measuring this parameter in our routine clinic practice?
I think that's going to be difficult. I mean, it sounds like science fiction, really, if we're going to do this routinely. What I would say is that the news is good, and that what people need to do is take on board these healthy lifestyle measures, which don't cost, and to start to adhere to them.
But how can we implement that in the primary prevention of our patient?
Well, we do need to make concerted efforts. If we look at the Eurospire survey, which was based on 16 countries looking at primary prevention in primary care, the number 40 comes to mind. 40% of people were obese, less than 40% of people exercised regularly, only 40% of people achieved blood pressure goals, and less than 40% of people achieved lipid goals. So we need to make much more concerted effort in actually preventing disease as well as focusing on cure.
Cecilia, we had a lot of information about sudden death. And do you think that environmental factor may be responsible for a certain number of sudden death?
Yes, I do. Environmental factors such as air pollution, hypothermia and dehydration may trigger arrhythmias provided there is a substrate. And we do know from small studies that ICD carriers may be more prone to shocks in days of high air pollution. So yes.
I think that therefore we have a big piece of information regarding the role of environmental factors, but something to do with hypertension too. We are living in the industrialized country. Hypertension is a very important risk factor. How is it combined with environmental factor to increase the burden of cardiovascular disease?
Well, I think we've seen some very interesting data from China, a huge country, and I think in 3 areas: air pollution influencing blood pressure, which has been well documented in other countries; dietary salt, an important opportunity to intervene and reduce blood pressure at a population level; and temperature, as Cecilia's just mentioned. Interesting, in the winter months, blood pressure goes up. And in areas of China where there's been a bigger deployment of central heating to change that in local regions, we've seen blood pressure coming down, and importantly, cardiovascular events coming down. So environment plays a really huge role in the development of cardiovascular disease.
Environment factors implies also maybe other factors. Any comments, John, regarding potential socioeconomic factors?
Yes, I think the telomere story is a fascinating story because it relates biology and something else we know about premature cardiovascular disease, which is it is more common in patients who live in socially deprived circumstances. And those individuals we know have shorter telomere length. They are prematurely aged. And this is about the greater environment. It's maybe about exercise, it's maybe about poor diet, but it may be other things as well: hazardous behaviours, stress, anxiety, all the things that go, poor housing, that go with living in these deprived circumstances. Now we've got the biology link.
So therefore, I think that the awareness of the cardiology community has increased regarding the environmental factor. And thanks to the data coming from Elizabeth Blackburn, we have now a very elegant link maybe between the environmental factor and premature aging. Unfortunately, I think that we cannot provide to the cardiologist the magic recipe for tackling the telomere attrition. So therefore,
but we don't need that, Genevieve.
No, we don't need that.
If we can modify the influence of the risk factors, those people who believe that genetics predetermined what's going to happen, they're wrong.
So therefore, we have to come back to the counsel that were given by our mothers and that reminded us Elizabeth Blackburn. First, sleep well.
Yeah.
Second, do exercise. And finally, eat healthy food.
Okay, so we're going to look into some specific risk factors and prevention. Let's see the next video.
Stay tuned for the next report.
Pathway is a series of trials conducted by the British Hypertension Society investigating the treatment of hypertension. In Pathway 2, 314 well-characterised resistant hypertensive patients were randomised to receive, in a sequential manner, either spironolactone, an alpha blocker, a beta blocker, or a placebo. Every patient took every drug for 12 weeks.
Saw that the best drug for most patients, in fact almost every patient, was spironolactone. Low dose, 25-50 milligrams a day, vastly superior to placebo and highly significantly superior to the other blood pressure lowering treatments.
In Pathway 3, 440 obese hypertensive patients who were not receiving a diuretic were randomised to have either amiloride, 10 milligrams alone, hydrochlorothiazide alone, 25 milligrams, or a combination of both at half dose.
The summary of the study is that potassium-sparing diuretic amiloride is as effective at lowering blood pressure as hydrochlorothiazide, but has the advantage of preventing any glucose intolerance. And when the two drugs are used together, we have a win-win where all the benefits of the two drugs are amplified in lowering blood pressure and their undesirable effects are cancelled out.
In London, Alberico Catapano, current president of the European Atherosclerosis Society, summarised the latest advances in LDL management.
We have witnessed really a breakthrough discovery in the recent year in the area of LDL lowering. We now have a full armamentarium of drugs, statins, inhibitors of cholesterol absorption, and PCSK9 inhibitors that will allow us to be very flexible in the therapy and very, very effective. The main take-home message is now there are no excuses not to reach the target, the goal for therapy that we have addressed in the guidelines, the common guidelines between the European Atherosclerosis Society and the European Society of Cardiologists. I know those goals are demanding. 70 milligram per deciliter is not easy to reach, 1.8 millimole. However, now the tools are there, and especially in very high-risk patients, patients with familial hypercholesterolemia, no excuses anymore. Detect the patient and treat them.
So, resistant hypertension, let's start with that, Bryan. I mean, you were the lead investigator for Pathway 2, and there's been a lot of concern about how we manage, how we identify what is resistant hypertension, and do we have some novel approaches to define this and to treat it?
So we looked at a population of patients that have been well defined now by the European guidelines. They have to be on 3 drugs, RAS blocker, CCB, plus a diuretic, blood pressure still not controlled. We were quite rigorous in making sure that their clinic blood pressure and their out-of-office blood pressure was not controlled. And also we looked at a variety of ways of assessing treatment adherence before the patients went into the trial. You know, it's remarkable that after 50 years, we still haven't seen a trial comparing different drugs for the treatment of resistant hypertension. So we tested spironolactone because there has been some evidence from small studies against placebo and observational trials that this might be a good drug, but we didn't know it was the best drug. And we went against a beta blocker and an alpha blocker, so we could block the sympathetic nervous system and also block renin with a beta blocker, just to see whether spironolactone came out on top, and it did. I mean, it was by far the best drug. It controlled blood pressure in the most patients. And at the end of the study, there was hardly anybody that we didn't get controlled or almost controlled with these 3 different approaches, but always spironolactone was superior.
So this has said something really interesting, that actually what we thought of as resistant hypertension, where we were told the arteries were fixed, is maybe not right. And it's a much more smaller proportion than we thought.
Yes, I think maybe the definition of resistant hypertension needs to be revisited, because I think personally, now that we know that spironolactone is so effective in many of these patients, it really should be defined as patients who are not responding to treatment with the 3 drugs that we recommended previously, plus spironolactone. And interesting, getting to your point, Keith, if we look at how many patients were left at the end of that study who would have met a criteria for randomization, for example, into a renal denervation study, where you had to have stage 2 hypertension, 160 in the clinic systolic, we would have only had 15 patients left.
Right. So this brings up a really interesting point, Marco, that the trials of renal denervation were innovative and exciting, but they didn't show an impact greater than optimal medical therapy. And maybe that was because the patients weren't actually getting and receiving, in part, or is it in part to do with the technique? What do you think?
I think renal denervation has 2 issues currently. Number one, obviously, it didn't work in the randomized control trial. So we have to go back and see, was the application way, where the device is wrong, where the patient not the right one. So we have to go back and see, understand more about the mechanism. And number 2, as just said, the population of the so-called resistant hypertension patient may shrink. There is one issue, that the adherence to medical treatment may be very different actually in clinical practice, as compared to the clinical trial. So I would, a word of caution with respect to adherence, I think it's appropriate.
Can I just make a point about that, Keith? I mean, we actually brought all the patients into the clinic. We asked them to bring their medication. We asked them to take their medication in front of us, and then we measured their blood pressure.
So we don't have the luxury of doing that sometimes in widespread clinical practice. And we must raise another issue, that there's a concern in the medical community about side effects of spironolactone, in particular gynecomastia. This was seen less often in this Pathway 2 study.
So the main concern that's restricted a lot of people has been potassium, I think, and renal function. 2 points about this study. We saw an increase in potassium above 6, but below 6.5 in only 6 patients. And each of those was managed very easily. There was no issues. But we did not include people with an EGFR below 45. So we don't have any data on the safety below 45. So they're 2 key points. The gynecomastia we almost certainly wouldn't have seen in our trial, because in my experience clinically, where I have used spironolactone for hypertension, it's often a few months down the line, and our treatment cycles were for 12 weeks. That was enough to see potassium changes, but not enough to see gynecomastia.
And in some previous trials, there was a combination with digoxin as well that may have contributed to some of the gynecomastia.
Well, that's mainly in the heart failure trials. Just to give the audience a perception of what kind of frequency of gynecomastia we see in hypertension, it's around 5 to 6% with spironolactone, giving at the doses that we gave here, 25 to 50 milligrams a day.
Yeah. I'm going to turn to John now. In terms of the related issues in heart failure, but sodium's the bad guy. Is that right?
I was going to ask Bryan that, because obviously spironolactone and eplerenone are very effective treatments for heart failure. So Bryan, was this about a diuretic effect, or was this an anti-aldosterone effect? Because of course in heart failure we believe these drugs are mineralocorticoid receptor blockers, and that's how they bring about their benefits.
Great question. I think it's likely that many patients with resistant hypertension, particularly those that have very low renin levels at baseline, have probably got primary aldosteronism that we haven't been able to detect, and they would certainly respond well to spironolactone. It may also be simply because we're using another diuretic in addition to the thiazide they're already getting, blocking sodium reabsorption at 2 points in the nephron, and therefore getting more effective diuresis in this sodium retaining state. We need to do another study looking at whether either increasing the thiazide or using an alternative to spironolactone can replicate this effect.
Are your patients not running out on amiloride?
Yeah, that's it. We actually decided at the end of the trial, because not everybody finishes at the same time, and we had to keep the study blinded, that when they finish the study, we would run them out on 10 to 20 milligrams of amiloride. the advantage of that was to see whether the amiloride replicated the blood pressure lowering effect of the spironolactone in the blinded component of the trial. We haven't yet had a chance to look at that.
So tease out
yeah,
the
it'll give us an
aldo
answer.
versus sodium.
Yeah, it's not blinded, but it will give us an answer.
So let's come to a related issue, and that's to do with thiazide treatment in hypertension and people's concerns about hypokalemia and also the concerns about glucose intolerance. And we also have really interesting information from Pathway 3 in relation to this. Tell us about that.
Yeah, so my colleague Maurice Brown led Pathway 3. And it was interesting because, you know, thiazide doses have been progressively reduced. And the assumption has been that we could do that without compromising the efficacy of thiazides. We did it to try and reduce the frequency of hypokalemia and also impaired glucose tolerance. What we did in Pathway 3 was to say, well, the thiazide induction of diabetes is thought to be related to the drop in potassium. So why not try and see what happens with a potassium-sparing diuretic? These have traditionally been thought to be a weaker diuretic on blood pressure, but we used a much higher dose. So we used amiloride 10 to 20 milligrams a day compared to hydrochlorothiazide 25 to 50. 90+% of the patients were already on an ACE inhibitor or an ARB, so we could deal with the issue of tolerability of amiloride to see if they got hyperkalemia. And actually, amazingly, as expected, the diuretic increased the risk of diabetes, increased the 2-hour glucose, but the amiloride reduced it. And the combination of the two, at half the doses used in monotherapy, neutralized the effects on potassium and glucose and gave us more blood pressure lowering.
So Bryan, you've clearly presented the findings from the study, but I want to turn to somebody else because clearly you were linked with the studies. Sure. I'm going to turn to Sanjay to talk about, you know, in your view, what's the significance of these studies and also in relation to different populations around the world?
Well, I think for me, the thing that grabbed me the most was that these are old drugs changing paradigm with an excellent outcome. These are as cheap as chips, spironolactone and amiloride and thiazide diuretics. And this is important in the current financial climate. The other thing, of course, is that I'm concerned about the impact on ethnicity because 5% of the British population is black and 13% of the American population is black. And these are the individuals that more likely have resistant hypertension and impaired glucose tolerance and will probably benefit the most. But we mustn't just limit this to Europe and America. We've got to think about Africa and South America where these countries are developing and finances are scarce. So these drugs could be revolutionary.
So here are generic therapies that could be added to standard of care with widespread applicability. And so we think that that's really an important take-home from this Congress.
Absolutely.
May I ask a question?
Yeah, sure.
I would like, because I'm near sure that after this meeting, all over the world, the spironolactone will be widely used. So I would like to ask you one practical question, because the people will start, of course, in the population with GFR higher than 45. But if during the treatment, the renal function will be a little bit worse, what do you advise?
It's a very good point. We looked at renal function with all the interventions. An interesting thing is, everybody who has blood pressure lowering with resistant hypertension, whether it's a beta blocker, alpha blocker, or the spironolactone, had a reduction in GFR. And that is related to the reduction in renal perfusion pressure, which we know is almost certainly protective in the long run. So if it's a small reduction in GFR, 10% fall, and that stays stable and doesn't get worse, carry on with the treatment, because that is just a function of the blood pressure lowering. But the point you make is very important. You must measure potassium and renal function after initiating this treatment within a couple of weeks, and then depending on whether there's a change or not, periodically thereafter, because we can't be complacent about the fact that we have an ACE inhibitor or an ARB and an aldosterone blocker on board, and we need to be careful to make sure we monitor these.
I mean, we've obviously got a lot of experience of that combination in heart failure, and everything you said's right, Bryan. I mean, it's almost that a reduction in eGFR is a marker of the effect of the drug, an indicator of the patients who are likely to benefit, at least in heart failure. So,
and in diabetes too.
A modest reduction in eGFR is not something to be concerned about, not something to make you stop treatment.
Okay, so some really important messages from that. Let's now turn to lipids, because there's also been some important information about lipids, the management of hyperlipidemia in diabetics, and also how low one can and how low one should go with the advent of the PCSK9 inhibitors. So Sanjay, what should we make of all this?
Let's start with the Improve It trial, whereby they looked specifically at the impact of the combination of simvastatin and ezetimibe on cardiovascular mortality, myocardial infarction and stroke in patients with diabetes versus people without diabetes. They managed to get the LDL down to less than 1.4, and they found that the absolute benefit in individuals with diabetes was 14% versus 2% in non-diabetics, suggesting that the diabetics did well. And this perception that low is good seems to be true. The other important thing, of course, is the PCSK9 inhibitors, which have now demonstrated that you can actually bring down the LDL to these levels in addition to statin therapy. In fact, if you add in PCSK9 inhibitors to statin therapy, you can bring down the LDL cholesterol by 50%, achieve targets in 80%, and this effect seems to be attenuated.
Even in heterozygous FHs?
Absolutely, and in high-risk cardiovascular patients. And these effects seem to be attenuated for up to 80 weeks.
So, and also an exciting study presented just in a poster here of an entirely different way, because the two PCSK9 inhibitors work in one way, but there's an interference RNA that can block with a single injection for 6 months, halving your LDL. Is this fantasy land? Is this...
Well, I'm an optimist, so I wouldn't say it's fantasy land, but I think anything that manipulates genetics needs to be studied in a bit more detail before we can actually accept this type of therapy.
So studied in more detail, and I'm going to turn to you, Victoria, because, you know, the elegant imaging techniques that we have at the moment and some that are in development, how can these give us insights into atherogenesis and what's happening in plaque?
That's a very good question, because there are already studies showing in patients with acute coronary syndrome that they are starting with these new therapies that actually you reduce the LDL levels, but the changes in plaque burden, plaque composition is modest. So we need to know a little bit more how these drugs can also give us a reduction in plaque burden that will give later on the new events, cardiovascular events.
So you've got the whole array of imaging tools at your hands. Which ones are you going to choose?
I think that one of the most widely used currently is intravascular ultrasonography, but there are also near-infrared technologies and other technologies that give us also the temperature of the plaque and can give us a more idea on how vulnerable that plaque is and when it's going to come the new cardiovascular event.
So I guess there's a watch this space about, you know, whether these profound changes in LDL may change some of the accumulation of lipid within the wall and within the plaque, but we need some studies to define that.
Exactly.
So, Janina, I'm going to turn to you. You know, we've made great progress in acute coronary disease, but what about the time after? Are we doing enough in lipid lowering?
For sure not. I can tell that we are not doing enough in secondary prevention, because if we are looking to the results of acute treatment of acute coronary syndromes, the results are good near all over the world, of the Europe. But when we are looking for 2 or 3 years long-term results, then we can see that we are not follow the secondary prevention indications. So that's the time and the hope that maybe injection 2 times per year will help with that, but it is a long story before us. But at the beginning, we have very simple thing to do. Just physical activity, stop smoking and so on, and also still use antiplatelet therapy.
Sure. And so, you know, one of the take-homes from this has been that from EuroAspire, we learned that we're actually pretty ineffective in dealing with most of the patients that we should be treating, both for primary and secondary prevention. So there's scope to do a lot with what we have already. So perhaps we should move to the next section.
This is a perfect introduction to the next session on coronary artery disease.
Coming up on the best of ESC TV.
Optidual is a French trial in which 1,385 patients were randomized a year after DES implantation either to stop dual antiplatelet therapy or to continue it for an additional 36 months.
In fact, we did not reach a statistical significance. Extended DAPT had a better outcome than aspirin alone, but the study was not powered enough to reach the statistical significance. However, our results are in agreement with the findings of the DAPT trial, showing the value of prolonging DAPT for 2 to 3 years after PCI, after the ES placement.
The platform study included 584 patients with chest pain who were evaluated using either FFRCT or conventional testing to see if FFRCT could reduce the rate of invasive coronary angiography that showed no obstructive CAD.
We were aiming to test the effectiveness of a CT, non-invasive fractional flow reserve guided care compared to usual care in patients with suspected coronary artery disease. And what we found was that among patients with a planned invasive catheterization, there was a dramatic reduction in the rate of not finding no obstructive disease at angiography from 73% to 12%, with no differences in adverse events or radiation exposure.
So now I turn in front of Marco, a question from a non-invasive cardiologist that I am. How long should be the duration of a treatment for dual antiplatelet therapy for our patients?
Yeah, obviously a very tricky question.
Do we have the answer from this meeting?
As mentioned, the OptiDual study was underpowered but suggested a benefit of prolonging dual antiplatelet therapy. This goes in the same direction as a meta-analysis just presented at the meeting, showing that pulling all the studies together, prolonged dual antiplatelet therapy was associated with a significant 22% relative risk reduction in MACE, corresponding to 1.1 absolute risk reduction in the event rates, and this relating to a number needed to treat of 90. So this is the positive aspect. This has to be weighted to increase the major bleeding in the same meta-analysis, suggesting that there is an increase significant in major bleeding in the range of 70%, relative risk reduction, 0.8%, absolute risk reduction, number needed to harm 125. So if we look at mortality, we can say the meta-analysis show indeed a reduction in cardiovascular mortality, but was really borderline, 0.3% absolute risk reduction. And there was no difference in overall mortality. So I think, and this is also the take of the guidelines, you have to assess the risk of the patient, bleeding risk and ischemic risk, and then decide on a case-by-case fashion. But for the first time, the guidelines opened the way to a prolonged dual antiplatelet therapy in patients at high ischemic risk and low bleeding risk.
You want to make a comment,
I was going to ask
Sean?
Marco, I mean, I know the guidelines do say that, but that's quite hard for the clinician. I mean, how do you as an individual decide whether that patient has that right balance of benefit and risk? What are the things that would make you practically continue versus stop?
Yeah, I think it's obviously a very important point. And we don't have so much it's difficult to discriminate which one is high bleeding risk, which one is high ischemic risk. Most of them there is overlap. So the suggestion is if you have a patient with acute myocardial infarction, you're undergoing stenting, then reassess the patient at 12 months. At this time, you may use the criteria of the Pegasus study, which was the largest one. So if you have a patient high risk defined as a patient who has diabetes, multivessel disease, renal insufficiency, maybe has already had multiple events, then you may consider a prolonged dual antiplatelet therapy if in the meantime it remained free of bleeding events.
This is for sure very important to consider the patient and to have a sort of personalized strategy according to the patients. But Janina, I would like to have some other comments from you regarding the type of stents that the patients are being implanted.
I would like to comment this meta-analysis because there are some very important points. One that mostly that was the second generation of the stents implanted at that time. Then the sub-analysis didn't include, I mean in the trials, we not included a patient with high risk of bleeding. So there is a preselection of the patients as usual. And the second thing, that there will be different definition of major bleeding. So I agree absolutely with you that individualization is the best way, and that we should come back to the indication after 12 months of the double therapy.
Yeah. And I mean, there are two trends, difficult to reconcile. First, if patients are stable and undergoing drug-eluting stenting, there is a trend to try to shorten the period of dual antiplatelet therapy. And this is possible because the newer generation stent have dramatically reduced the incidence of stent thrombosis. On the other hand, we want to prolong, but this not to reduce target lesion associated rates, but we want to prevent progression in other area of the coronary tree. So it's very difficult to reconcile the two trends.
So, yes,
well, I was
Bryan.
just going to make the point, Marco, that there is a focus on whether it's stenosis within the stent, but of course many of these patients are at very high risk of ischemic events elsewhere, including stroke. And it looked to me as though the dual antiplatelet therapy in the very high risk populations, that's an area where you might get benefit beyond the coronary. So it really is much more complicated, isn't it, than just looking at the type of stent and everything else. I mean, it's not just the stent, it's the overall ischemic burden.
Absolutely.
Again, in this very high-risk population, we have the risk because most of them, they had atrial fibrillation, and then we need to use anticoagulation, and that's the new story, but
yeah,
maybe
this is definitely another chapter that was addressed in the guidelines, and I would encourage you to get into this.
So, Marco, one quick question for practitioners. If you do elect to use dual antiplatelet therapy to continue, do you give gastroprotection? Do you give a proton pump inhibitor? Do you give a H2 receptor blocker? Is that worthwhile? Does that reduce the bleeding risk? Are we still concerned about PP?
Yeah,
eyes?
I'd say, so the guidelines tell us that in order to qualify for proton pump inhibitors, you have to have additional criteria. So at least two about having more than 65, having already bled, or having some positive finding for risk factor for gastric ulcer. So clearly there is not the concept of giving PPI to everybody.
And now, I would like to ask Victoria, what do you think about this new imaging technique, FFRCT, that combines both the morphological and functional assessment of coronary artery disease? First of all, how does it work?
Thank you, Genevieve. That indeed is a new technique that has been developed in the last few years, and actually answers one of the needs that we have when we evaluate patients with suspicion of coronary artery disease. In clinical practice, sometimes without whether we send the patient directly to invasive coronary angiography, or we send the patient for detection of ischemia, or we evaluate the patient with another anatomical tool, like, for example, CTA. But the previous studies have shown us that CTA can give us a more defined diagnosis of coronary artery disease, but can increase the referral to coronary angiography, invasive coronary angiography, by 50%. And then we can have a significant proportion of patients that do not show obstructive coronary artery disease. This FFRCT technique is a technique based on CT data, where we apply specific computational models on hemodynamics that simulate the administration of adenosine. So we can simulate how much stenosis, how much significant that lesion is. And we can indicate, or we can think that if that is true significant, then we can refer the patient for invasive coronary angiography without having the risk of having no obstructive coronary artery disease.
So I would like to comment on this, because it's really very exciting, although we have to say that it's not ready for prime time. But I mean, if we make a little bit the history of coronary disease and imaging, so we started with angiography, just looking at the coronary artery. Then everybody was telling us this is not the right way, we should go for ischemia. And then there was a trend. Now go back to imaging with the CT, and now maybe in the future we will have both aspects of them. So really exciting.
I think that is really exciting field. And I think that we need, this is a platform, is one of the first clinical trials to see how this imaging technique can impact in clinical practice, but certainly we need more trials to see which are the prognostic implications.
Because we don't have yet any data on outcomes based on this technique. This is important to
Cecilia, you wanted to come in on this.
Yes, I do have a patient safety question for you, because going over coronary angiograms in registries, 30% of them are normal. So would this new technique make coronary angiograms unnecessary, because they are not totally free from complications? So I would really appreciate if some of my patients could go to CT instead.
Yeah, that is a very good question, but the problem is, again, how do we stratify, how we improve the pretest probability of coronary artery disease of patients with suspicion of coronary artery disease. So far we have exercise test or functional imaging with SPECT or with stress echocardiography or CMR stress, and we have shifted in the last years a little bit towards anatomic evaluation with CTA. And what we need actually is to know whether these lesions that we see on anatomy evaluation on CTA are significant or not, are hemodynamically significant. And this FFR-CT technique has been validated against invasive FFR, that may be a way to improve the pretest probability of these patients.
So, John, you wanted to come in?
Yes, I mean, I think there's another patient safety issue, which of course is the radiation dose, but there are still a lot of questions to think about this. So how long does it take to do? How long does the computation take to do? How much does it cost? And then what is the dose of radiation?
Yeah, the dose of radiation is the same that for CTA, that has been compared, that is similar to an invasive coronary angiography. The issues for the technique, currently the platform trial sent all the data to a specific core lab where they have the a dedicated software to analyze this, and takes 48 hours to get the results. So actually we need, it's rather fast, but probably we need a faster evaluation, maybe in other set of patients. But in terms of radiation, doesn't add an additional radiation. Issues for this technology, if we read the platform trial, you will see that between 10 to 12% of the patients, this technique was not feasible. You need a very good image quality, and the heart rate of the patient should be appropriate to get a good visualization of the coronary tree. So these are things that probably we need more work on it and see if we can improve that feasibility.
So Victoria, not quite ready for prime time, but there's no doubt that there's a need for people like Marco and his colleagues around the world not to go to the cath lab and do an angiogram on people with normal coronary arteries 30% of the time. So what can people do in the meantime with the kind of non-invasive imaging techniques that we have?
So actually the guidelines already also indicate that we have large possibilities to improve the pretest probability of the patient. So we have exercise EKG, or we can add imaging with stress echocardiography, with myocardial perfusion imaging, or even with CT perfusion or stress CMR. So depends on the availability of these imaging techniques in your institution and your expertise. You can decide to one of these techniques to improve that pretest
so these
probability.
are currently in the guidelines, but not always applied.
Keith, I would like to make the comment. It's very important that we differentiate stable patients from acute coronary syndrome patients. So
these are stable patients.
Stable patients.
This is stable patients.
So acute coronary syndrome is completely different. Risk stratification is basic, and invasive strategy is very predominant.
It's very clear. It's very clear. So let's move to the guidelines, because there's new information in the guidelines from new guidelines at this Congress. Great.
The key message of these guidelines is, first of all, use very well medications to treat patients with myocardial infarction, heart failure, hypertension, and so on. Medications are there and should be used properly. Second, identify families with risk of sudden death and extend the evaluation of the substrate to the family members to prevent sudden death that is genetic in origin.
The main take-home messages are that we can now diagnose myocardial infarction faster, within 1 hour, after admission through the use of these high-sensitivity troponin assays, that we suggest transition to a transradial approach for coronary angiography and PCI. And we give personalized recommendations for the initiation and for the duration of dual antiplatelet therapy, which are largely based on the individual bleeding as well as ischemic risks of the patient.
I think the new guidelines give us the precise treatment for acute pericarditis, for recurrent pericarditis, for pericardial effusion, for tamponade, for constitutive pericarditis, the precise indication when to go back to exercise for normal people, for athletes, for people who have perimyocarditis, that's to say pericarditis with myocarditis, how to treat pregnant women, how to treat children, and how to treat all the spectrum of the disease of the pericard in the field.
The diagnosis should start with a good echo, but then right at CAS is mandatory to demonstrate the existence of pre or post capillary pulmonary hypertension. Treatment strategy have improved a lot in high risk and lower risk patients, and there are causes like CTEPH which can be surgically cured, and we should never forget to identify these patients.
The main messages are the following. First, no change on prevention, only patient with the highest risk with the highest risk procedure. Second, change in the diagnostic procedure will focus on other imaging techniques than echocardiography, more and more frequently useful. Third, major new concept is the concept of endocarditis team. And finally, surgery will be necessary in half of these patients, and we do not need to delay surgery in these patients.
So, Cecilia, arrhythmias, preventing arrhythmias, ICDs, optimizing medical therapy, what should we do?
I think one of the most important messages in VA guidelines is stressing the fact that we should wait to sit from 6 to 12 weeks for drugs such as beta blockers and ACE inhibitors to improve left ventricular function after myocardial infarction. And at that point, we can decide whether a patient is indicated for a primary preventive ICD, which will do benefit provided the left ventricular ejection fraction is below 35%. But which will not be helpful for those with high ejection fractions. So that is one of the key messages. The other one is that in the event of a sudden cardiac death, an autopsy should be performed to assess whether there is a cardiomyopathy or potentially a hereditary channelopathy. And in such a case, genetic testing of the rest of the family should be performed to avoid other sudden cardiac deaths in that family.
Yeah, this is very challenging, isn't it? Because sometimes somebody inherits the genotype, but not the phenotype. So, Sanjay, what should we do about this? You know, you've got great expertise with athletes. What should we do?
Well, certainly, I would like to emphasize one of the important things is actually how we assess the family of a victim of sudden death.
Yeah.
An autopsy conducted by an expert pathologist is absolutely prudent because that would guide which way we take our investigations. Clearly, if there's nothing found, we're looking at a sudden arrhythmic death syndrome and we're targeting ion channel diseases.
Sure.
And if we find something structurally wrong, we're targeting primary cardiomyopathies. It's absolutely prudent that these families are investigated in a highly expert center where there are experts in cardiomyopathy, ion channel diseases, genetics, genetic counseling, and there is a good cardiac pathologist, because the yield in these situations is about 50%. You will find disease in 50% of first-degree relatives, which could be life-saving, of course.
Well, that's a pretty high yield. Not all studies have found that, but important messages. Great. So what about the next topic?
The next topic, imaging, the role of imaging in the guidelines, and we're beginning with the infective endocarditis. Well, echocardiography remains the cornerstone for the diagnosis of endocarditis, but there are new players coming. Can you comment on that, Victoria?
Yeah, exactly. Transthoracic echocardiography is the main imaging technique, but we need to think also that there are now novel techniques like CT to improve the diagnosis of the presence of complications, such abscess, for example, or MRI to see whether there are microbleeds in the brain or other embolic problems. So I think that you always need to think a little bit beyond transthoracic echocardiography, and when there is still the suspicion, there is the next step that is transesophageal echocardiography, but you need to think also that there are these other imaging techniques that can refine the diagnosis.
And that may be very useful in very special cases, such as like valvular heart prosthesis?
Particularly in valvular heart prosthesis, computed tomography can give a better resolution of the presence of abscess, and also important to comment on the PET-CT techniques, for example, although that should be careful when you perform these imaging techniques, because if it's too early after surgery, you can still have some positive findings that may not be endocarditis. So you always need to know the pros and cons of the new imaging techniques.
Not too early, not before 2 months for the use of PET-CT. Yeah.
So Janina, there's some practical advice as well about when to transfer patients.
Yeah, this is a practical advice. There is a new definition of infective endocarditis team. Which means that in these high expert centers should be the expert not only in cardiology and cardiac surgery, but also imaging, neurologists, microbiologists, and others, some from congenital heart diseases, which also define these high expert centers. So
the patient can be
endocarditis team, right? And so the high-risk patient should be treated from the very beginning in these high expert centers. That means who is the high-risk patient? The patient with heart failure, and also the risk of embolism, and some patients with uncontrolled infection, that they are the candidate for urgent or sometimes emergency surgery. But on the other hand, some, let's say, easiest way of easiest patients with endocarditis can be treated in their own center and just be in touch with this.
So the guidelines helping us on who to transfer. So
yeah, who to transfer and who can be only consult from time to time in this reference center.
Pulmonary hypertension.
Yes, pulmonary hypertension. I think, again, going back to Victoria, the role of imaging and especially echocardiography is, has been described again, and we have more parameters for to be sure to measure, to be sure of pulmonary hypertension.
Yeah, that's correct. In the previous guidelines, we only measure the gradient through the tricuspid valve if the patient has tricuspid regurgitation. But the current guidelines also include other parameters that may indicate that the patient has pulmonary hypertension, like, for example, the inferior vena cava diameter, the area of the right atrium, and Doppler parameters of the pulmonary artery and pulmonary artery diameter. So I think that they have a much a more thorough evaluation of the patient with echocardiography than just measuring the gradient through the tricuspid valve.
So that's very important to integrate all these parameters, but, well, nevertheless, the echocardiography is not enough to ensure the diagnosis of pulmonary hypertension.
Exactly.
We definitely need to get a confirmation from catheterization.
Exactly. When there are all these signs on echocardiography that indicate that probably the patient has pulmonary hypertension, the guidelines include also or recommend that you are in touch or you refer the patient to a specialized center where they can perform also the right heart catheterization and refine the diagnosis of which type of pulmonary hypertension the patient has and which is the most appropriate treatment for each type of pulmonary hypertension.
And again, these guidelines highlight the importance of heart team and more specifically pulmonary hypertension team with reference center. This is crucial.
Yeah. So also new guidelines on non-ST segment elevation ACS. And you know, one of the issues is what do we do about the people presenting with chest pain, and how can we rule them in or rule them out? So maybe turn to you first, Janina.
Well, maybe I will first talk about hot topic trial being presented, back trial. And they show clearly that during the first hour, we can safely rule out the patients that they have low troponin I level, high sensitivity level, the presentation in 1 hour after that. They even shown the point of cutoff of the level of troponin I.
6 nanograms per mil.
Yeah, and it shows that about 50% of patients can be ruled out. Looking for the overcrowded emergency room all over the world, I think that it is very important information and very important result.
Okay. So there's also information about radial approach.
Yeah. First of all, let me go back to the trial. We were very happy to see the result of this study because this endorse the result, endorse the current recommendation of the guidelines just released, proposing 1 hour algorithm with high sensitive cardiac troponin in the emergency room as an alternative to the so far proposed 3 hour algorithm. So now we have both options, both with the same class of evidence.
So importantly, a potential to unclog our emergency rooms by getting more accurate diagnosis, both in terms of the sensitivity and specificity.
Definitely.
Okay. What about any other areas from the non-STEMI guidelines?
Yeah.
What about pre-treatment?
So exactly, I would say there are two additional areas of interest, pre-treatment, and the second one would be the radial approach. So let's start with the pre-treatment. So I would have to say that the approach has a little bit changed. Early on, there was, I may say, an over-enthusiasm in the efficacy of pre-treatment, meaning giving a P2Y12 inhibitors in patients scheduled for early coronary angiography. So, but last year or 2 years ago, there was some sobering result coming actually from the single trial that addressed this issue, showing that prasugrel was not efficacious and was deleterious in this setting. So the current guideline tell us not to pre-treat the patient with prasugrel, just do it in the cath lab. And with respect to clopidogrel or ticagrelor, the guidelines do not recommend to do it or not to do it because simply we don't have trial looking at this. So you are free to do as you think it is appropriate.
Okay, great. We better move to the next section.
Yes, we are going to move to our last topic, heart failure.
You're watching the best of ESC.
In SERVE-HF, 1,325 systolic heart failure patients presenting central sleep apnea were randomized to receive either adaptive servoventilation or medical management alone. Median follow-up was 31 months.
We found actually there was no difference in outcome at all. And surprisingly, which has taken both respiratory physicians and cardiologists completely by surprise, we found an increase in mortality. And if you look at cardiovascular mortality, it was up 34%. So not only does it not make any difference to the patients with systolic heart failure, it actually increases the risk of them dying. So this is a real game changer trial, really important.
3D printing is entering the area of valvular imaging and repair, as illustrated by the first 3D printed tricuspid using transthoracic echocardiography.
We hope that it will facilitate the communication with the surgeons, with relatives, and it also will hopefully provide us with more insights on the tricuspid valve pathologies. And the hope is that after advancing our understanding, we'll also be able to project much easier the future percutaneous intervention dedicated for a tricuspid valve that now are emerging in the field.
A leadless single pacing pacemaker has been evaluated in the Leadless 2 study, a non-randomized trial in which 300 patients from 56 North American centers has the device transfemorally implanted in the right ventricle. Vivek Reddy summarizes the key findings 6 months after implantation.
Number one, the device can be implanted in 96% of the patients. Number two, there's about a 6.5% rate of major complications, and we expect this to decrease over time. We have to remember that 99% of the operators had never performed a device implantation before. Number 3, the vast majority of patients, once the device is successfully implanted, has adequate sensing and pacing over the long term. And number 4, the expected longevity of this device is out to 15 plus years.
MentraPath study is a randomized comparison of catheter ablation and antiarrhythmic drug therapy as first-line treatment for paroxysmal atrial fibrillation, and 5 years follow-up results were reported in London.
After 5 years, there was a significantly lower burden of atrial fibrillation in the catheter ablation group than in the drug therapy group. Significantly more patients were free from any asymptomatic atrial fibrillation in the catheter ablation group than in the drug group, and only 3% in the ablation group and 5% in the drug group had developed persistent atrial fibrillation. That's very few. 2 years, the patient's quality of life score was significantly better than at baseline in both treatment groups, and with no difference between groups. And now, after 5 years, still quality of life is significantly better than at baseline with both treatments and without any difference from 2 years.
Well, John, were you surprised by the results of SERVACHEF? How can you explain this increase in mortality?
Okay, well, the first question is the easy one to answer. Yes, I was very surprised, as I think everybody was. As you know, this was a trial of a certain type of assisted ventilation in central sleep apnea, and there was a 30% increase in mortality. Can I explain it? Very difficult. There are lots of theories. Some people believe, for example, the hemodynamic effects of this ventilation could be detrimental in patients with severe heart failure. That's a possibility. But there's a very interesting counter theory, which is actually central sleep apnea may be a protective adaptation in heart failure, and that by countermanding that you make patients worse. Now, I think we'll be able to tease this out in heart failure because there's another type of treatment for central sleep apnea, which is phrenic nerve stimulation. That's being studied at the moment. That has no hemodynamic effect, so it will sort of tease out whether this was a harmful effect of the ventilation or whether it was a harmful effect of actually affecting the central nervous system abnormality. I think the messages for physicians here are that you shouldn't use assisted non-invasive ventilation in patients with central sleep apnea, but it's still got a very important role to play in the relief of obstructive sleep apnea. And of course, we all use CPAP and other forms of assisted ventilation in our patients with acute heart failure, where we know it's safe from a large trial called 3CPO and is effective in relieving symptoms.
It comes up with a new topic also. We have been aware and we have concerns about drugs which are lowering in our patients with heart failure and diabetics, the glucose level.
Yes.
So did we get any new information from the studies being presented at the ESC Congress this year?
You're absolutely right. We were very concerned last year following the SAVOR-TIMI 53 results showing that a DPP-4 inhibitor might increase the risk of heart failure because, of course, heart failure is the most diabetogenic state that there is, and anywhere between 30 and 50% of patients with heart failure have diagnosed and undiagnosed diabetes, and we need new treatments. And this looked like a promising type of glucose-lowering therapy, but then there was this safety concern. At this meeting, I think those safety concerns were put to rest because a much larger trial called TICOS showed that another DPP-4 inhibitor actually did not increase the risk of heart failure. And there was an additional study with a different type of incretin-based therapy, a GLP-1 analog, a trial called ELIXA, in acute MI patients, also did not show any concern about increased risk of heart failure. So I think those concerns have been put to rest.
Do you want to make any additional comments on this, Sanjay?
Well, I do, yes. I mean, it was a non-inferior trial, but we should still be punching our arms in the air about this because the situation is that although glycemic control has a very modest effect on the actual heart, it's got a very significant effect on microvascular complications, notably retinopathy and nephropathy. And of course, blindness due to diabetes is the commonest cause of blindness in the Western world. And so in this particular situation, normally people with heart failure, they've only got insulin or metformin, but only in a very small number of cases, because many of these people have also got impaired creatinine clearance, and therefore metformin is prohibited. So I think the fact that we can now use another oral hypoglycemic agent to prevent microvascular complications is a very big deal.
Great. Let's move on to another topic, because we had this fantastic new 3D printing of a tricuspid valve. First of all, do we really need it?
Well, that will come probably in the future if we really need it. There are already some experience, for example, with congenital heart disease using CT or CMR that have much higher spatial resolution to create the models where the surgeons can decide and tailor which is the best approach for each patient. And this is for the first time from transthoracic echocardiography, 3D transthoracic echocardiography, getting the model of the tricuspid valve. Really needed, we don't know. There is the growing field of transcatheter interventions where we don't see the structure directly as a difference from the surgeons, and where we need really a detailed anatomical evaluation of the patients. The tricuspid valve is a sort of the forgotten valve sometimes, and we have this growing population that have been operated in the past from the left side, from the mitral valve or the aortic valve, that come back again with tricuspid regurgitation, and they have a very high risk for surgery, and they may be admitted recurrently because of heart failure. And now there are evolving new techniques on transcatheter tricuspid repair, where this technology of 3D printing maybe can help us to tailor the treatment of the patient.
Do you think that it might also apply to the other valves, such as the mitral valve, because it may help in discussing with the surgeon having such a tool?
Yeah, there are already some experiences on the communication between the surgeons and the cardiologists, how to treat the patients, for example, with mitral valve with 3D transesophageal echocardiography. That technique already gives us a very good information, anatomical information of the mitral valve. But if in addition to that, you can print it, you can have it in your hands, or you can even imagine that you can print similar tissue characteristics of the mitral valve. You can see what happens if you apply certain ring or if you apply certain techniques of plication. So you can, for each patient, personalize the treatment that you want.
Excellent.
So we saw some interesting information at this Congress about leadless pacing. And Cecilia, my question to you, leadless, but perhaps needless?
Good start. Well, as a pacemaker doctor, I would like to get rid of the leads and the pacemaker pocket because they're related to complications. Now we have hopes for the future, I would say, because there are now two types of leadless pacemaker that are being studied in observational trials. And this is one such, Leadless 2, in which 300 patients who were indicated for a VVI device, a very unusual indication in cardiac pacing. They were implanted with a 4 centimeter, 5 millimeter width device into the right ventricle, and they achieved their goals. They had a high successful implantation rate. In inexperienced implanter who had no previous experience of leadless implantations, they had good pacemaker function. But there were some complications, and that is, in my opinion, related to the 18 French introductory sheet that is involved in the placement of this device, and which may potentially also damage the tricuspid valve, I don't know. But they reported the complication rate, which they said was comparable to pacemaker registry. If you go to the Danish pacemaker registry, which is ongoing, the complications that were serious, such as cardiac perforation and tamponade, are actually higher in this study than reported in this registry. So it's not free from complications.
So an innovation that's on the way, but not quite ready yet.
Yeah, I think
and
that's
you know, the place for single chamber pacing these days is maybe quite limited.
I would say about 10%.
About 10%. Okay, now there's also been interesting data on the follow-up of AF ablation and the impact Tell us about that.
Yes, I think most of us, when we consider RF ablation in an atrial fibrillation patients, we go for trying a drug first, an antiarrhythmic drugs, and that goes pretty much with the guidelines. But the Mantra PAF trial was interesting in that this challenged this approach and tried RF ablation versus antiarrhythmic drug as a first-line therapy. And what they showed over the 5 years is that 15% more patients in the RF ablation group were free for any atrial fibrillation, and 10% more were free from symptom-related atrial fibrillation compared to antiarrhythmic drugs arm. So I believe it really emphasizes that we should perhaps consider RF ablation a little bit earlier than we are currently.
But quality of life identical at the follow-up?
It was.
Okay.
But there was a substantial crossover in this trial. 50% of those in the antiarrhythmic drugs arm went over and had RF ablation over those 5 years.
All right. So we come to the last bit of this round table, where we're going to go round the table and ask everyone for their final take-home, the individual take-home from this Congress. And perhaps, John, we can start with you.
Well, actually, I think SERVE-HF reminds us of something that is fundamentally important in cardiology. There are many observational studies that suggest assisted ventilation is associated with a better outcome in patients with central sleep apnea. We've now done the randomized trial and got the opposite result. We must do randomized trials. That is the basis of our evidence in cardiology.
Sanjay?
Over 34,000 people came here to manage established cardiovascular disease. But the results from Eurospire were disappointing, and I think we really need to focus hard on preventing cardiovascular disease.
Okay. Cecilia?
Well, for me, the possibility to treat hypertension with conventional drugs already available is the major take-home message. There aren't that many patients with resistant hypertension.
Okay. Marco?
My take-home is go radial. So now the guidelines give us...
it's in the guidelines?
Yes, class 1A indication for radial, because radial not only reduces vascular complication, bleeding complication, but now also mortality. So we really encourage all the centers that are taking care for patients with acute MI to switch from femoral to radial.
Okay. Victoria?
For me, I would highlight the increasing role of multimodality imaging in several heart diseases is also included in the the new guidelines that have been presented here, and also the possibility to give us the possibility to tailor the treatment of each patient.
Bryan?
I think a constant theme for me was seeing all of this new innovation coming through and this discussion about the benefit versus risk. And it's not always clear-cut, and it's very difficult to define, whilst at the same time we hear evidence of our inability to adequately deploy cheap, safe, effective treatments that we know work and do reduce cardiovascular disease.
Yep. Janina?
I'm fascinated by these new anti-hypercholesterolemia drugs. You know, I think that it is absolutely new field, and that it can change secondary prevention and also primary prevention.
Okay. Genevière?
Well, I think that Elizabeth Blackburn, our guest host, has opened our mind on the fact that the environmental factors may lead to premature aging. And it comes up with a proactive theory that maybe aging is a primary disease and cardiovascular disease is just a symptom of this.
So aging is modifiable?
Oh, we hope so. And yours?
Okay, I can't get away without one. So, I mean, for me, there's been huge advance in the last years in acute coronary disease. And what we're seeing is therapies that are very hard to demonstrate additional benefit. But actually, after the acute coronary syndrome, there's a really important ongoing risk of events, and we haven't tackled these well enough. So in closing, we want to highlight what's coming up next year.
Well, we're looking forward to seeing you in Rome for ESC Congress 2016.
Great. Thank you all.
So I'm looking forward to welcome you in Rome next year, 2016, where the world of cardiology will come together.